colonoscopies aren't my wheelhouse. But with that, I mean, I think for most parts, people continue to take their medications throughout the prep. But you can always, I mean, since you're not really having significant solid fatty food intake when you're doing a prep, it's not unreasonable if you want to hold it because you're going to just poop it all out. And so that may it's really at your discretion. So honestly, but I will say uh every anesthetic and adult practice is a little bit different in terms of their rules. So it's probably not unreasonable just to give them a call, whoever sent you the prep, or if they have a nurse practitioner or a nurse in the practice, to just confirm with them and say, hey, I'm not eating anything solid. Can I hold my Creon or should I continue to take my Creon? Because the last thing I would hate for what to happen would be is you took your Creon and they were like, you're not completely NPO, and then they cancel your colonoscopy. So I would just advise to double check.
Probably all about kids.
Okay, perfect. Then the second question that somebody sent was SDS patient, 24 years old, recently noticed change in the gastrointestinal system, had a stem cell transplant 3 years ago, have noticed that I do not have a big appetite since then. Before I would eat 3 meals a day, but now I feel full with only 2 meals. In addition, I'm often bloated. I'm wondering if this is a result of the transplant or maybe an issue with the dietary change that is needed. What is the best kind of diet to follow to help with bloating, and how can I help alleviate an issue if it's not just an issue with diet?
Yeah, great question, but also a lot of complicating things going on here, right?
Yeah.
Particularly the fact that we've already undergone a transplant and not understanding what your baseline was. So I think in this is a scenario where it's probably best to be either seen by a nutritionist or a gastroenterologist who can kind of try and understand what your dietary intake is, what your intolerance is secondary to. Is it a dietary intolerance? Is it a motility issue? Is it related to current medications that you may be on? So it's a little bit more nuanced than just saying, is it because I should try certain things? I think when you have a change in your diet that's new, it's worth being seen. So someone can work this up a little bit more.
Perfect. Thank you. Okay. That was it for questions right now, before the show. If
Okay.
you'd like to start up, you're more than welcome to.
Perfect. Well, I just wanted to thank you all for having me come and speak today. Um, I apologize if I was gave the impression that I was a little bit behind, and I also apologize that I'm dressed as if I'm from the OR because that is what I am doing. I was not
Oh,
intending to be stuck this late in cases, but as Murphy's Law would have it, that's how it is. So I was very grateful and fortunate this past year to get a chance to speak at the Congress. And I was asked to speak on the gastrointestinal phenotypes of SDS. And just as a big disclaimer here, as a reminder, I am a pediatric gastroenterologist, and so my experience is typically in children with the GI. Is Do we need to mute someone, or is my
Yeah, that's what I'm thinking.
Yeah, we're
yeah.
getting feedback.
yeah?
Thank you.
Um, just a disclosure that I am a pediatric gastroenterologist, and I'm happy to be as helpful as I can and provide any advice that I can. We just got to be mindful that there are certain things that are within my wheelhouse and certain things that are definitely not. But I wanted to start by presenting what I was able to present at the Congress, and I'm happy to answer any questions. And as I was introduced very nicely, I didn't need any of those accolades. Everyone just knows me as Grover, so we can just forego any of the formalities here, okay? So I want to start with a clinical case, which is a case of a patient of mine. Not too uncommon, this presentation, you know. There was a 37-week infant who was induced secondary to intrauterine growth restriction with maybe concern for being small for gestational age. But, an unremarkable delivery, no perinatal complications, initially breastfed with some catch-up growth, which was great. But at about 2 months, they started noticing that the growth velocity was just veering off the growth curve a little bit. So they continued to follow it, and at about 4 months, they decided to transition to formula, which was supplemented to 24 kcal, not an uncommon thing, and some more frequent pediatric checks for weight checks. And then you kind of saw this further separation from the growth curve. At around the 6 month visit here, the patient had a Z score, which was negative 3.3, or less than the fifth percent, less than the 0.05th percentile. And now the patients were also saying, at 6 months, their stools are a little bit weird, they're mucousy, they may be a little bit shiny. The pediatrician appropriately recommended an elemental formula because we think, this is probably a milk protein intolerance, which we see very commonly, and a referral to a GI clinic, particularly my clinic. And so, this is me in clinic, less fur. And so I was seeing this 8-month-old who came for growth faltering. And when we review our records beforehand in part of our consultation, we need to make sure that there was a normal newborn screen, which there was. There was really no significant family history of any GI or endocrine or pulmonary disorders. They were still taking their 24 ounces of fortified formula plus solids. Yeah, there was some shiny, soft, looser stools, but this was a happy, playful baby. And then the parents said to me, yeah, this baby has a rash. Can you just have a look at it? And I said, sure. And then I saw this, and then I had to kind of delve back into my general pediatric days, and it prompted the question of what additional workup should I be doing with this? This is, we call this petechiae. So of course I got some screening blood work, some screening CBC here. Um, you know, I'll be fully honest. Most gastroenterologists don't look at the differential. We leave that to our hematology colleagues, but I also got a differential. Um, I got a chemistry panel, a metabolic panel, some stool studies, an abdominal ultrasound, a sweat test. And here we can see off the bat, like our chemistry panel showed this really high ALT, which is a measure of liver transaminases. We also saw is it on this screen here? Our sweat test was normal. We had a significantly low vitamin D, and all pointing towards some concern for impairment in absorption. Stool testing showed a fecal elastase of 5 and an INR that was mildly elevated, indicating some possible degree of liver dysfunction. So, I think we know where this is going, obviously, given today's talk. And just FYI, the ultrasound did not visualize the pancreas due to overlying bowel gas, but this is not an atypical or uncommon presentation. So, in terms of an outline for today of my talk, I'm going to really break it down on the GI phenotypes based on organ system, what we think of most often in Schwachman. And we'll start with the pancreas because that's what we know the most about, and that's the area of my interest. We'll then move on to the small bowel and a bit on nutrition. And then, with some time, I'll hopefully touch up on the liver. So, as you all know, the hallmark of Schwachman is the presence of impairment in exocrine pancreatic function. Even in the first paper by Schwachman, Diamond, and Oski and Kaw, they called it the syndrome of pancreatic insufficiency and bone marrow dysfunction. Bodian, in his seminal paper, referred to this as a congenital hypoplasia of the exocrine pancreas. That he describes the Schwachman phenotype is being very different from that in cystic fibrosis, where you had near loss of the acinar cells and fatty replacement. But there was good preservation of the ducts and islets, which is different than what you might see in a CF patient, where you have destruction of the duct cells and the acinar cells. And so what is all this? What does this mean? So if I were to kind of break it down, this is the functional unit of what we call the exocrine pancreas. It's made up of these cells called the acinar cells. And then you have ductal cells, which line the duct here. And these acinar cells are super metabolically active, and they produce what we call these zymogens, are these granules that have these inactive enzymes that then come down into the duct and they travel. And then the duct cells secrete water and bicarbonate all into this lumen that goes into our GI tract. And this is what helps us digest our food. I mean, these are just some of the enzymes that are secreted. And at its most simplistic level, what we've learned from those early studies was that there's low acinar volume because these acinar cells are taken up by fat. And this leads to less production of these enzymes for secretion into the GI tract. And when you're not releasing enough enzymes, we're really not able to digest our food. And then that's when we get these manifestations of fat malabsorption, and fatty stools are what we call steatorrhea. But we have to remember that we need fats. There are essential fats that we need for growth. There are fats that are needed to help us digest various types of vitamins and micronutrients. Um, I think what's really important to mention, and I say this to all the patients that I see, is that it's really not an all or none phenomenon um, in terms of the symptoms and the degree of malabsorption or even the degree of steatorrhea. Excuse me. Um, the classic literature and the early studies by Dr. Drury and others reported that, exocrine pancreatic insufficiency is often present in early childhood, which leads to this picture of shiny stools, oily stools, steatorrhea, which is a clinical manifestation of malabsorption. And while it does start in early infancy, the it kind of gets better and it resolves, particularly after 4 years of age. There were really elegant studies that looked at changes in fecal fat over time, or even studies that looked at enzyme secretion, and where they looked at different types of enzymes that are secreted by the pancreas, the trypsin, the lipase, and that these improve with age. Um, there's even data to say that as many as 50% of patients are able to discontinue their enzyme supplementation after the age of 5. But I think this for me has been a real question that I'm still trying to tackle, and I'm trying to work with other folks across, is like I see so many of these patients and I wish I could tell you, you know, our data from our registry says that, you know, 80% of children over the age of 10 are off enzymes. 50% of like I want to be able to get some of these numbers so I can really put this out there. We just don't have it yet, but it's something that I'm interested in trying to look more into. When we have looked at some of our registry data, again, it really highlights the variability in the phenotype or the presentation. And this is like one of the classic papers by, Cass, Myers, and Akiko, which looked at 37 patients who had, the classic presentation of neutropenia and diarrhea, but this was only in 50%, you know. 58% reported some diarrhea. Um, 14 out of the 17 had, what we report is that textbook lipomatosis or fatty infiltration on ultrasound. Some patients had none. Um, you know, Only 82% had a low fecal elastase, which meant 20%, 1 in 5, had normal stools. Um, all this to say is that, just because you don't have neutropenia or diarrhea presentation, or if you have normal pancreatic imaging or normal fecal elastase, it doesn't rule out the diagnosis of Schwachman. So you kind of have to have that in the back of your mind, okay? Um, but when I see this degree of variability in pancreatic function itself, it's hard for the pancreatologist and me to not think of another condition that I manage quite regularly, and that's chronic pancreatitis. And you have to remember that the pancreas is a dual gland. It has both exocrine functions and endocrine functions. And while 95% of the mass or tissue of the pancreas is composed of exocrine cells, so the cells that make enzymes and so forth, 5% are endocrine cells, which make diabetes and hormones and so forth. And so I see this in chronic pancreatitis where kids have scarring of their pancreas. And, what are the implications of having impaired exocrine and/or endocrine function? I mean, first of all, we know in exocrine pancreatic insufficiency, maldigestion leads to malabsorption, which leads to nutritional and growth deficiencies. The clinical symptoms of steatorrhea can cause pain, they can cause bloating. Being on restricted diets and having to take enzymes for every meal, like we were just talking about, you take your enzymes before colonoscopy prep, can have a huge impact on your quality of life. And then we also have to worry about ensuing endocrine dysfunction, the implications for lifelong diabetes and even possible pancreatic malignancy. I think about this more so in my chronic pancreatitis patients, but it's still there. And this is relevant because, truthfully, we can treat and replete this, which is great. If we have impairment in exocrine function, we can give enzymes, we can give the fat soluble vitamin levels that we need, so that's a positive. I just wanted to take a quick second here to talk about exocrine pancreatic dysfunction. So we all refer to this as EPI typically, exocrine pancreatic insufficiency. But I think exocrine pancreatic dysfunction is probably should be used or more aptly used to describe that this is a spectrum of impairment in function. Most of the adult literature now on the pancreatitis side really describes this as being a spectrum or various stages of dysfunction, because even in its own name, EPI implies an all or none phenomenon. You're either sufficient or insufficient, but it doesn't really account for those in between degrees of impairment. And a review came out a couple years ago, which was really great, and it talked about and I really like the statement that they made is that you have to remember that the digestive capacity of the GI tract is largely, but not wholly, depends on exocrine pancreatic function to achieve near complete digestion and absorption of ingested food. This paper really outlined and defined how we look at exocrine dysfunction. And you have to remember that exocrine dysfunction only manifests if the digestive need is not met by our exocrine reserve. And that there can be many things that can cause this. Steatorrhea, which is the hallmark symptom of exocrine pancreatic insufficiency, doesn't manifest until we've really impaired about 90% of our enzyme producing capacity of the pancreas. And so that really makes us think, okay, well, there are other factors we should be thinking about. And, you have to think as a gastroenterologist, what is the differential diagnosis for chronic diarrhea or fat soluble insufficiency or vitamin insufficiency, and how do we explain this discordance? Like, could there be reserved pancreatic function? Are there other sites in the body or the GI tract that lead to lipolysis? Are there other causes of maldigestion that we're not thinking about? Bacterial overgrowth, celiac disease, has the patient had evidence of surgery? So when we're testing an exocrine pancreatic insufficiency or exocrine pancreatic dysfunction, there are some things that I think we need to consider that we do. So, well, first of all, what are the features of an ideal test? It needs to be accurate. We like them to be non-invasive, widely available, easy to perform, and importantly, cost effective. But we also have to ask, what are we trying to measure? Are we trying to measure degrees of fat malabsorption? Are we trying to measure pancreatic function? And how objective tests are they interpreted? Is this a snapshot in time, or is it dynamic? Are we following it over time? Is this a transient assay? Is this something that's a more permanent thing we're looking for scarring? Is there a decline? Is there improvement? And I think most importantly, no matter what testing we do, we have to ask ourselves, is it clinically relevant? So, you know, the indications for pancreatic function testing in my practice are typically evaluating for exocrine dysfunction or insufficiency in patients who have clinical symptomology, really to define the extent of their pancreatic function, particularly in patients sometimes with CF. I need to rule out chronic pancreatitis in patients who have inconclusive imaging or findings, or in children who have an unremitting chronic pain. But I also have to be able to differentiate if this is a luminal problem, is this a pancreatic problem? Are these specific enzyme deficiencies? So there's so many things that come into play here. When we think about function testing, we often describe them as indirect or direct. And so indirect are non-stimulatory testing, whereas direct is more stimulatory. And what we're measuring here are the consequences of exocrine dysfunction. So evaluating the downstream measures of these impaired pancreatic secretions and enzymes. They're non-stimulatory. They tend to be less expensive, less invasive, and easier to perform. And the gold standard that has always been the case, which many people remember, is just fecal assays. You know, what we do is as gross as it sounds, you go on a diet that is, monitored by a dietitian. So we're quantifying the amount of fat that goes in our diet, and you collect your poop for 72 hours, and you're able to quantify the amount of fat in there, and you calculate a coefficient of fat absorption. And that's kind of, as laborious and gross as that sounds, kind of one of the gold standards that we've had. It's hard for families to follow, right? It's hard for you to limit what your child's intake is and make sure that you're measuring exactly what it is and collecting every poop and keeping it in the fridge. It's not straightforward, but that is, one of the assays that we used to have, and it's not invasive. We all know the fecal elastase. This is a test which measures what are called chymotrypsin-like elastases. And it's the most commonly employed indirect test for exocrine pancreatic insufficiency that most centers all use now. The beauty of this assay is that, what we're measuring for is not degraded by bacteria. It can stay, these elastases stay stable in feces for up to a week at room temperature, a month when stored in the fridge. And it's not affected by the use of enzymes. So you can do a fecal elastase test if you're on enzymes. So if someone tells you you have to hold your enzymes, no, you could totally do this assay. A lot of our data based on the fecal elastase has been validated in the cystic fibrosis population. But again, it doesn't necessarily correlate with the degree of impairment. And what I mean by that is I've had patients who have a completely low fecal elastase, um, and they're growing weight and gaining well, which then leads to that question I asked before is what leads to this discordance? And are there other areas that are helping with our lipolysis or causing that are extrapancreatic in nature? The important thing to remember if you are doing a fecal elastase assay is that it really should be on a semi-solid stool, because dilution or like diarrhea can actually lower artificially your fecal elastase value, which leads to a false positive. Um, Other assays we used to have before the fecal elastase, one was called the fecal chymotrypsin. It's less sensitive and specific. It can be degraded by bacteria, and this one does require the cessation of enzymes. The steatocrit is just a quick kind of spot test where you can look under a microscope and see if there's fat in the stool. But if you're having oily poops or like a picture like I showed of that toilet bowl earlier, you're going to see oil fat there. So it's not the greatest assay. But then we also look at surrogates of fat malabsorption, and these can be measured by serum markers that help support the diagnosis. And as you all know, we look at for fat soluble vitamin levels, the 8X, vitamin A, vitamin E, vitamin D, vitamin K. Other indirect tests include breath tests. Some centers offer this. It's like a breath test that you would do for lactose intolerance, and you can use various types of marked radioisotopes in a meal, and it can be used to typically assess the efficiency of your enzyme replacement therapy. It's really non-invasive, but it does have variability and it fluctuates with activity level. I mean, these are challenges we have with all types of breath testing. If you have delayed gastric emptying for whatever reason, if you have some gastroparesis or other intestinal issues like bacterial overgrowth, it can affect these. There is a urinary test, but it's less accurate than a fecal elastase. And so we don't typically do that as often. But what's really interesting is that to further expand on the serum assays that we use in our pancreas population and our pancreatitis population, I mean, this was a real pivotal paper that came out years ago, by Dr. Drury, which they looked at pancreatic serum trypsinogen and isoamylase levels in patients. And this is kind of what we use as our gold standard, is that trypsinogen typically is a good identifier for pancreatic phenotype in children less than 3, whereas older than 3, we use the isoamylase. But again, it helps us identify the phenotype, but it does not necessarily correlate with the function or symptoms. If we move on to more direct pancreatic function testing, and I remember when I presented this at the conference, some of the families there remember this type of testing. These tend to be a little bit more invasive. But they tend to be the most sensitive and diagnostic tests for exocrine impairment. And it's based on direct stimulation of the pancreas. So you often will give an IV of something called CCK or secretin, which stimulate the pancreas to release its enzymes. And then at the same time, you're collecting this fluid. And the old school test that used to be done was something called the Dryling tube. And this was first done in the early 1950s, where you would put in two tubes. You would put a tube in the stomach and a tube in the duodenum, and with one you're sucking up gastric fluid, and then the other one you're sucking up pancreatic fluid, and then you stimulate via IV, and then you're taking these aspirates out over time. You know, this is a cumbersome assay. It requires radiation. It's laborious. It requires anesthesia. It's time consuming. So it's not the most straightforward test, and it puts patients through a lot. What we've been able to do now is far less, I want to say, challenging than the dryling tube, is we actually do it when patients are undergoing an endoscopy. And so this is what's called the papilla. where pancreatic enzymes are released through here. And this is a catheter coming out of a regular scope. And we do this during a standard endoscopy. And while the patient is under and they're getting an infusion, we give them the CCK or secretin. And then through a little catheter in the location of here, we're able to take these aspirates and aliquots. And then we send it off for pH, electrolytes, protein analysis, enzymes such as amylase, lipase, trypsin, chymotrypsin. The problem is the studies haven't showed the greatest concordance with this, and I think across multiple centers, there really isn't a standardized protocol. So the way I may do pancreatic function testing endoscopically may not necessarily be the same way as another pediatric center. I think there aren't really great age normative values for this assay, so I think it's hard. We kind of base it on kind of conglomerate data. Um, if the samples aren't sent on ice immediately or collected, it can affect enzyme levels. And, we do know from data that various anesthetic agents can have an effect on the pancreas. So maybe that's going to skew these. So we don't typically do direct pancreatic function testing that often. Um, I think it's also important to remember that the exocrine pancreas and the acinar cells don't exist in isolation from the endocrine pancreas. I mean, here in this picture, all kind of these pink cells are those acinar cells that I showed you before with like the duct lumen there. But these are the islet cells. These are the cells that make insulin and different types of hormones. And I think it's beyond the scope of today's talk, but we know Schwachman patients may present with endocrine manifestations, including neonatal hypoglycemia or growth hormone deficiency, but also with type 1 diabetes. And this has been reported elsewhere. Um, so you can't think about one without the other. I want to move on now to intestinal manifestations and piggybacking on the concept that there is heterogeneity in the phenotypes and clinical symptoms. It begs the question as to what else is happening in the GI tract. I don't think it can just be all the pancreas's fault. Everyone wants to just blame the pancreas, and that's fine, but I think there's probably more going on. And while the pancreas is important in digesting what we eat, we have to remember that the bowel is important in absorbing what we eat. And I think the notion that the bowel may be involved has been solidified. There was a paper, I can't believe it's been 2010, by the group at Great Ormond, which looked at patients who were being evaluated for poor growth, but who ended up having Schwachman. And almost 50% of them showed that there was some changes to the epithelial lining of the small intestine, what we call villus blunting or duodenitis. And this is kind of what we see here. So normally in the small intestine, you see these finger-like projections. I tell my patients it's like a shag carpet, that allows you to absorb what you're eating. But if you have blunting or atrophy, it just flattens here. And you can't absorb as much as you can. And so that has an impact. There was an increased proportion of these kind of inflammatory cells in the duodenum, which is where we absorb a lot of our initial nutrients. There was another study more recently in 2015 where they saw autoimmune-like disease and anti-gliadin positivity. And all this means is that you have this enteropathy, which kind of mimics what looks like celiac disease, which we know patients will often have poor absorption and poor growth. More recently, there have been some papers that have really looked at this idea that there could be this pro-inflammatory phenotype. In 2020, the group by Nissen et al. Showed a patient who actually also had Crohn's disease, which is a type of inflammatory bowel disease. So to say that the intestines aren't involved in this picture, I'm not sure I believe that. In 2020, Furutani et al. Showed that they looked at a case series of 5 subjects, and 3 of them had other autoimmune conditions. This study here in 2025 reported that, Schwachman patients had lots of pro-inflammatory markers, which tell us that there's probably something inflammatory going on here. And I think this is something that we need to look more into. But at the end of the day, what does this mean for us? Well, I mean, there's growth implications, right? And we know this, but what are the growth implications and what does this mean for each patient? I mean, if it was just as straightforward as repleting the enzymes and controlling the inflammation and giving adequate nutrition, then we would expect to see a normal growth phenotype, but we don't. So that really makes me wonder what else is going on here. This was kind of one of the pivotal studies back in 2015 where they looked at 21 patients with Schwachman. And while the majority of them had exocrine insufficiency, but they were all on enzymes. And yet still, while repleting them and giving them the things that they needed, almost 50% had deficiencies in fat-soluble vitamins and trace elements. 30% had vitamin deficiencies, 19% had these trace element deficiencies, which we typically look for, copper, zinc, and selenium. Some flaws in this study were that they didn't really have good dietary intake records, and there was no evidence of the degree of fat excretion or whether the enzymes are working. But I mean, the point being is that if it was just as simple as saying, okay, it's an issue of not getting enough enzymes or not getting enough nutrition, you would think that if we repleted the enzymes and gave them more nutrition, our growth would be the same, but it's not. And there have been studies, by the Italian group and now even by the group at Cincinnati, which have shown that, patients have their own growth trajectories in this disease. So there's something more going on here that I think we need to really think about in the GI tract. Um, what I was able to do before presenting this was, I did want to look at our registry and, based on the 246 patients with confirmed biallelic mutations, I was able to see that 62% of them actually underwent endoscopic evaluation. And now my goal is right now to try and further interpret this data and look at the pathological findings. 38 of them had an EGD or upper endoscopy. 5 had a colonoscopy alone. 6 of them had endoscopic pancreatic function testing, like those direct tests that I was talking to you about, where you give the IV and you collect the fluid. So I'm interested to see what that data shows. What else did I gather? We saw that about 85%, 85 patients in the registry at some point reported some type of feeding or enteral tube support, either being a gastrostomy tube or an NG tube. And 28 we're still seeing a nutritionist and dietitian, which, if you've heard me speak before at camp, I think this is really, really helpful and really, really important. So, we've looked about the pancreas, we've thought about nutrition, we've thought about the small bowel. The question that always comes to me as well is what's going on in the liver. And I think truly the liver and the hepatic manifestations of Schwachman really do remain a black box, albeit in the right upper quadrant. But that said, there's very little that's been studied in this space. And, we actually have some preliminary data that we're looking to put out for publication that we've submitted that I can't really talk too much about yet until it gets published. Just kind of outlining the phenotype and what's going on with the natural history of liver disease in these patients. And kind of a spoiler alert is that, we do see these high rises in um, our enzyme levels, but thankfully for the vast majority of patients, very few of them go on to develop severe disease. However, it still is something that we have to watch out for because there have been reports of this. And I think thinking about what happens after transplant is something that we have to be mindful of as well, because, the liver is a very important organ. But if we look at what has been published, this was the big paper that came out looking at liver disease from children who from childhood through adulthood. And one of the more common things we often saw was hepatomegaly, and elevations in the ALT, or these are liver assays, were observed in young children, but often, thankfully got better. There was a Finnish study that showed there were some elevations in bile acids, which did raise the concern for any kind of cholestatic or kind of what we think about jaundice type manifestations. But the changes on biopsies were really pretty mild and not shown to be progressive. But as I mentioned, there have been liver complications that have occurred in older children, especially those who have undergone BMT. I just kind of want to take a little bit of a sidetrack here, which, I pose this as the gastroenterologist, and I wonder if there is a role for endoscopy in Schwachman. Um, it's very hard to justify putting a patient through an endoscopic procedure unless you know you're going to get some information that you're going to act on it. It's an invasive test. And I'm fully aware that, if there's no symptoms or nothing to suggest, involvement, you may not have to do this. But during an endoscopy, we're able to take tissue samples that children don't feel of the esophagus, the stomach, and the small bowel. During an endoscopy, we can do pancreatic function testing. One might argue that if a patient is going to be under, as it is for perhaps a bone marrow, adding on a 10-minute endoscopy may give some more information that could be helpful or may allow us to determine certain things. One of the newer modalities that I'm fortunate enough to be able to do is something called endoscopic ultrasound. And with an ultrasound probe on the end of your scope. So just imagine if you have an ultrasound on a belly in the setting of a pregnant woman. And ultrasound allows you to see all the layers beneath the surface. So similarly, if I have an ultrasound inside the stomach, I can look at everything around the stomach. I can look at the liver, I can look at the pancreas. I have the ability to put a needle into the pancreas directly and take biopsies. I can measure the stiffness of the liver. I can obtain liver biopsies. These can all be done. There are limitations based on patient size and so forth, but these are all things that a gastroenterologist has in their toolbox. Here, this is just a little clip. So that's with my scope in the stomach, and that's the liver. I'm just rubbing my scope right there. All that kind of yellow stuff, that's the liver right there. And I get a very good view of the liver from one end to the next, which is really, really cool that we can see this from within. That's my aorta. I do not want to go near that. That is not something that I like to intervene too much upon. And what's going to change now is I'm going to drop down, and what you're seeing here, this kind of outlined salt and peppery structure, this is the pancreas. And this is the pancreas duct that secretes those enzymes that we often look for. And this is the kidney coming into view here, the left kidney right here. This is our left kidney. This is the spleen, this kind of structure right here that's going back and forth. But yeah, we can get a really, really good view of a lot of the internal abdominal structures just by doing an ultrasound. So, some take-home points that I really kind of want to remind is that, from a GI perspective, I really think we're just seeing the tip of the iceberg. And as I've mentioned before, much work needs to be done. I think the GI phenotype in Schwachman is variable and it's heterogeneous. While we have an understanding of pancreatic dysfunction, much is still known. Much is still unknown about the intestine and the liver. I will say that, and I try and convey this to my trainees that come to Pancreas Clinic with me, you know, I think we should consider exocrine pancreatic dysfunction rather than insufficiency, as I think it conveys a spectrum of impairment rather than an all or none phenomenon. And I think it's always worth discussing the ways to measure pancreatic function because I think it's a really elaborate process. And are there other newer assays? Some companies in industry and pharmaceuticals have approached me to think about are there other measures that we can use? And people are thinking about this. But I also think, given some of the case reports that we've been seeing lately, is that inflammatory phenotypes should be considered in atypical presentations. And maybe we need to work this up for inflammatory conditions like IBD, like we saw in some cases. Um, I thought it was pretty interesting that if you were fortunate enough to be in Cincinnati for the Congress, sorry, this is where home is. Um, but we went to the museum one day and on one of the nights of the gala, and um, there was this section in the gala which really had the bloods area and the digestion area, which were right next to each other, which I really thought, symbolized the role that the gastroenterologist has in the Schwachman population, especially with the hematologists. But with that, that was what I presented. So I will say thank you for that, and I will stop sharing.
Okay, I have a couple of questions that were sent in. Question number one, what effect does fatty pancreas have on enzyme production as the patient ages?
So what's really interesting is um, in patients who don't have Schwachman, fatty pancreas is turning out to be something that a lot of adult gastroenterologists are looking more into. I'm sure you guys have heard of fatty liver disease, right? And the question that's kind of being discussed in the pancreas community now is there a fatty pancreas disease? And is this having implications? I think from a Schwachman perspective, what's interesting is that if we just assume that fat infiltration is leading to impaired um, secretion of enzymes, um, that's fine. But we're seeing patients who are then quote unquote outgrowing this, which tells me that there's something a bit more going on here. You know what I mean? I think we just don't know enough about one, the molecular mechanisms by which fat is getting stored there and it's causing this infiltration. But two, what is it doing? sometimes when I see fatty infiltration in other organs, you have to remember that fat is a pro-inflammatory mediator. So fat in itself can be inflammatory. And is that having some role in inflammatory signaling as well? I just don't think we know, especially in our population. You're muted.
Yep. So my next question would be, can you recommend if a child who is 6 years old should supplement with probiotics or other supplements to help aid their digestive system?
Yeah.
And then he wants to know, how often should fecal testing be done? And at what point would you recommend a child doesn't need to take their pancreatic enzyme?
So all fantastic questions. Um, in my general practice, I think and probiotics are great, right? You have to be mindful of probiotics in patients who have central lines, who are immune compromised, and this is where you have to be careful when giving them. But generally, for good gut health, I I recommend them to most of my patients. In terms of how often should you test a fecal elastase? That's a great question, right? Because you're taught that you should really only test if you're going to do something about it. Otherwise, we're just turning patients into guinea pigs, right? And so if there is a clinical change, I often will do some testing because I need to try and understand what that clinical change is. Um, like I said early on, I want to do this study with the families and the foundation and send out a survey to try and understand how many patients came off enzymes and what age did they come off enzymes? And can we look at this by looking at pharmacy data and validating this? Because I would love to be able to say to patients and families, you know what, based on the data that we have from our registry, we know that 80% of all patients were off enzymes by this age. We know that 50% of patients were off enzymes by this age. I can't give you that data, and I think that's something that I would love to be able to do. And it may be something that I'm going to continue to work on with the registry folks to see if we can get that data.
Question you just brought to my head is, do CF patients come off their enzymes, or is that a ongoing as well?
Most often they stay on them. You know, they unlike the phenotype is the histology is a little bit different because with the CF patients, they actually have destruction of a lot of their duct cells, and they have damage to the pancreas. Here it seems less like that and more like there's this fatty infiltration. So it's a little bit different. And so the CF patients typically are on enzymes for life.
Okay. Next question. Are you aware of any children who have developed fatty liver disease?
I haven't come across it yet, but it's something that I've actually asked one of my hepatologists here, and he hasn't yet either. And I think it's 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 not lost on me that this is something to look out for, but I can't say I've seen it yet in my population.
Okay. What is the optimal dose for Creon for infants and younger kids with SDS? And are there any problems with using too little?
So everything in terms of dosing, I think it's hard for me to kind of give solid recommendations in this setting because obviously I can't do it until I see the whole picture. You know, there are standard dosings that we use. And I think this is where it's important to work with a dietitian, um, or someone who has some experience in dosing because there's lots of things to consider. It depends on you can't just say an infant because is this an infant on formula? Is this an infant who's taking solids? Is this an infant who has purees? Is this an infant who has feeding difficulties? Is this an infant who's G-tube fed? You know, so I can't just give us, you know, because we have formulations of enzymes which kind of go in a cartridge for G-tube based formulas. You know what I mean? And as much as I would love to be able to give a number, I think it's just hard for me to do. And I think that's where working with a dietitian or an expert in that space, our gastroenterologist will be usually helpful. So I apologize if I can't give you a specific number, but I think it's something that people can help you with, you know, if you see them.
Okay, perfect. How would you test for SDS child's phenotype?
I mean, this is a clinical diagnosis, right? So that's what the phenotype is if they meet this clinical manifestations, and we're seeing it based on our transaminase elevation, our poor growth, or if we're seeing this, like this is what these, like that first case that came to me, clinically, that's how they come to my attention. We make the diagnosis based on confirmation through genetic testing.
How often would you recommend imaging of the pancreas for SDS patients with EPI?
I don't think it's going to change anything, truthfully. I like to get it to see if it can confirm anything. But more frequent imaging is just putting kids through unnecessary testing unless it's going to change anything. If there's a clinical change, then yeah, I would often think about it. But again, why put them through unnecessary testing?
And is there a particular formula you recommend for SDS patients, 19-month-old with pancreatic insufficiency, using Vivonex currently, but haven't found many others on this?
Yeah. So Vivanex is a great formula, right? Vivanex has some good fats in there that are easily absorbed. You know, um, there are so many formulas out there, and I think this is a prime example of where I stand by having a dietitian with expertise in pancreatic or malabsorption, because while some formulas may be good and have supplementation in some regards, you need to make sure that they are covering all your nutritional needs, which vary as children get older. And so while Vivanex may be what you're on right now, which is a fantastic formula, things may change when the 19-month-old becomes 24 months old or becomes 5 years old. And so it's hard to give specific formulaic recommendations. And this is where working in conjunction with a gastroenterologist or a nutritionist is really, really important.
Okay. Does ongoing tube feeding from a young age lead to negative GI implications?
Well, we have lots of patients who are dependent on tube feeds, for non-GI, for non-Schwachman indications. Do I like having a tube in patients if I can avoid it? No, if they can get everything they need and their gut is working, I would prefer to have that. I don't jump to putting a tube in most patients if I can avoid it. Um, are there there's a stepwise progression that we have to really evaluate if we're going to think about putting a tube in someone, right? Could they get by with an NG tube before you put in a surgical tube? Um, are the patients actually growing appropriately, but the person who's analyzing them doesn't understand that patients have a different growth trajectory in Schwachman, and just because they're less than the first percentile doesn't necessarily mean they need a tube. They're growing, their growth velocity is great. But a lot of people sometimes get hung up on the fact that, like, oh my God, they're not on the growth curve, I need to put a tube in them. I don't. Now, if there are patients who are faltering significantly and not maintaining a good growth velocity and having concerns for malabsorption, and they have whatever, for whatever reason, aspiration or oropharyngeal issues, or they can't get enough in by mouth, then yeah, we can think about a tube. But we have so many other patients that are non-Schwachman that are tube dependent, and they do fine. So I'm not opposed to tubes. If we need it, I just want to make sure that we need it before we go to that route. And if we do use it, then we do everything we can to supplement and use it as little as possible, but also trying to continue to work on all the other occupational therapy, oral therapy, physical therapy to help them try and eventually get off that tube. But if they're on it, they're on it. Like, I have tons of kids who are just tube dependent because for whatever reason they can't swallow, they can't eat, they aspirate, and they do fine.
Perfect. If nobody else has any other questions, we all would like to thank you so much. We did record this video, if that's okay, and we will follow through with getting this out for the people. If I do get any other questions, I'll email you at a later date. But I think your day and time are good for us right now. You can get out of your scrubs. Thank you so much.
I'm sorry I'm late, and thank you guys for giving me the chance to talk to you. I'm always here and I'm always happy to help. And yeah, it was nice to see everyone.
Perfect. Thank you so much. Have a great night.
You as well.